Good day. My name is Zeno Franco. I'm an associate professor in family and community medicine at the Medical College of Wisconsin, and I'll be presenting the paper Augmenting Google Sheets to Improvise Community COVID-19 Mass Distribution on behalf of myself and my colleagues listed here. I'll be focusing quite a bit today on the health disparities associated with segregation in the city of Milwaukee. Milwaukee is a secondary city in the Midwest of the United States with a population of about 600,000 people and about 1.5 million people in the metro region. It is the second most segregated city in the United States by ethnicity and is also very highly segregated by economic status. The African American and Southeast Asian communities are concentrated on the northwestern part of the city and the Hispanic communities on the south side. And there are significant health disparities for minority communities in many different health areas, including cancer, infant mortality, and environmental toxic exposure. And you can see a historical map here of redlining, sort of enforced segregation, and that has had significant impacts in terms of many different of the diseases that I mentioned. So lung cancer mortality here, you can see on the northwest side of the city, and also on the south side of the city has much greater incidence than for some of the communities that are primarily white along the sort of edge of the city next to Lake Michigan. And those problems with racial disparities in the city really played out at the beginning of the pandemic. Here's April 9th. You can see GIS visualization and the incidence of COVID-19 really falling in the African American community, and the total deaths also differentially impacting the African American community. And then very quickly thereafter, we had also a hotspot in the Hispanic community. This left us with the question of how to address the mask needs for an entire community in an equitable way under conditions of extreme scarcity. Almost all of the commercially available masks were being diverted to the healthcare system and were reserved for healthcare workers only. And we were trying to find alternative solutions that were not commercial grade masks for the community as a whole. But we also needed to address questions around how to change mask wearing behavior in the United States, where it's very uncommon to wear masks. Culturally, some other countries, just do this by kind of nature to deal with maybe air pollution or other factors. But in the U.S., wearing a mask is seen as kind of weird and really wasn't very common prior to the pandemic. So we had to start to advertise in ways that were culturally adapted for minority communities to get this message out there. We actually had a set of DJs produce a song for us called Mask on It, which you can hear on Spotify or Apple Play. You can also think about how we started to address the informational needs for the Spanish-speaking community on the south side of the city by going to this website and taking a look at the public health messaging campaign that we put together. As I mentioned, another major factor was trying to make sure that we actually had masks to give to people, not just that we did the information campaign, but that we could back that with actual masks that were going to be put in people's hands, because there was such a profound scarcity of masks in the community. There was so much fear. And so we started working with a manufacturer who had melt-blown polypropylene on hand, which is the same material that's used in surgical masks. It has an electrostatic charge that prevents small droplets from being transferred across the fibers in the material. And they actually found a way to fold that material up, put a couple rubber bands on it, and fashion an improvised face covering that had very nice filtration properties. And we had a two-way logistics supply chain going. So we had the manufacturer producing the materials, shipping them oftentimes through a community partner that we had who had a large truck in palletized form with 700 masks in each one of these boxes, but they needed to still be assembled. And so we actually managed the assembly at the Medical College of Wisconsin with student volunteers. And we were also pushing materials out for assembly into the community with folks from Boy Scouts and Girl Scouts, churches, and other community partners helping us assemble the masks. And then a return direction where we're trying to think through sort of equitable distribution of the masks and really using community awareness and awareness of sort of the overall network in the community, how to get masks to particular social service agencies that could then distribute them into communities of color. And this kind of comes into kind of a command and control view of community engagement in the context of crisis, using those medical student volunteers to deliver masks in their cars, and ultimately the community point of delivery. And here you can see delivery happening through the window of an agency called Ayuda Mutua on the south side of Milwaukee. We decided to really prioritize delivery to federally qualified community health centers, often called FQHCs. These clinics receive federal funding through the U.S. Health Research Services Administration to provide primary care to underserved communities throughout the United States. FQHCs in the Milwaukee region serve about 85,000 people, with more than 85% receiving some form of insurance support. And deliveries were managed to the FQHCs through campus-led community engagement connections. So we weren't just delivering to the front door where the masks could get lost, but instead we were handing off in a coordinated way through personal relationships to clinic operations managers to ensure that the materials actually got to the people that we were trying to get them to. We did have reports from clinical managers that patients were sometimes taking boxes of masks that were there, the surgical masks, because they were so afraid of what was going on, and that actually left less kind of commercial grade masks for the healthcare workers. So it was very critical that we got these improvised masks out as quickly as possible to the clinics. This slide is really the crux of today's presentation, and we use Google Sheets to list a very large number of community social service agencies that could use masks. So that the students could quickly go through and find agencies that needed to take a delivery. And we also wanted to be sure that we could display an accurate number of masks that had been delivered to each agency. And so we used a combination of Google Sheets, Python, and SQLite to manage this process so that new deliveries were read from a dedicated column in the Google Sheet, checked for errors, and then stored in the SQLite database and passed through Python, tabulating deliveries at each location and fed back into Google Sheets here in this column. And so the students could rapidly see sort of what was going on at each agency, which had or had not taken deliveries. And the different types of information are listed here. We were also using the sheet to prioritize visually for the students, so we had operational chunking occurring, and we had comments also occurring so that the students were able to communicate to the faculty and to the data managers about what was going on the ground. The students had some interesting innovations. So what they did is use Google Maps to create the most efficient routes possible for deliveries. We actually didn't have that many student drivers, and we needed to be sure that they were doing as much as possible on each pass. This is something the students initiated, not us. They also started taking photographs of each delivery so that there was assurance for the faculty and for the manufacturer that the deliveries were occurring. This also helped with community agencies when the delivery was unattended. If there was sort of confusion about where the delivery had occurred, they could go and find it. Here's a photograph again of an attended delivery, and all of these delivery photographs were really crucial. Interestingly, the students also were using paper-based systems, so they were taking data from the Google Sheet and putting it onto a post-it note on each box so that there was sort of concordance between the physical and the digital. And I think that's a thing that we often don't take into account when we're building software. Using this, we were able to rapidly achieve 50,000 masks delivered in the first few days after the shutdown. When we hit Easter, there was a bit of a slowdown, and we actually had to use a simplified set of decision rules to start to accelerate, and we were able to rapidly get up to about 250,000 masks, ultimately crossing about 262,000 masks by May 1st, 2020, and really trying to get those masks out to, again, the communities of color who needed it most. And toward the end of the process, we actually started concentrating on depot deliveries, going back to what we had sort of assumed would happen at the early stage of the disaster. As agencies started to reopen, it was possible to deliver very large-scale amounts of masks to them. And so we concentrated on backbone organizations on the north side and the south side, and also in some outside counties as well. And ultimately, we moved the operation to Pfizer Forum, a large warehouse facility at a sports center, and other agencies began to take over the logistics management, and the medical college started to pull back as we scaled up. And so we were actually able to use some of the data from the Google Sheets to facilitate that scaling process and transfer of the operation to folks that were ready to take it up to a much higher level of distribution, ultimately reaching 3 million masks delivered in the Milwaukee area. And to conclude with some research considerations and possible future directions, we've really tried to decenter research methods, deliberately placing this slide last to emphasize that we've taken a multi-actor action research approach. We've switched roles from researcher to responder. Where data collection often is systematic, we've taken a more opportunistic view of data collection here. And there have emerged divergent understandings between the different actor groups. So faculty, students, the manufacturer, and community members who helped us with logistics all saw the events very differently. And using an after-action research framework, we backtracked, expanded the discussion, and looked for documents, photographs, and small stories to help us understand what occurred. Through that, we're really suggesting that we need to augment available software in some of these situations instead of focusing on formal systems that have been used in humanitarian logistics. In some of these cases, there's a deep need for lightweight software solutions that are smaller and appropriate for early stage response with non-traditional actors, that have intuitive user uptake, again, augmenting existing widely used commercial data management platforms that people are already comfortable with, and that are contoured to the specific needs of that disaster and built from the ground up.